Hello, everyone. Thank you for joining us this afternoon. September is a Lymphoma Awareness Month. We are pleased to present Lymphoma, the Basic and Beyond. My name is Gemma Kim, and I'm the moderator for today's ACRSS Health Talk. I am the program manager at Asian Cancer Resource and Support Service at the Asian Health and Service Center. Before we get started, I'd like to give you a brief overview of who we are and what we do. Asian Health and Service Center in Portland, Oregon launched new services to Asian community to address the full cancer continuum, ranging from prevention, screening, treatment, to survivorship support. Our bilingual staff and volunteers are assisting cancer patients and their family members who speak Cantonese, Mandarin, Korean, and Vietnamese. Our goal is to increase the culturally, linguistically appropriate cancer resources, education materials, and support. We provide community-based cancer patient navigation services. To learn more about our services we provide, please visit our website or contact us by email or phone. Today's presentation will be recorded for future training purpose. Please mute yourself when you are not speaking. We will also turn off your camera and audio to minimize background disturbance. Please type the questions in the chat box. We will collect the questions and have a Q&A at the end of the presentation. Today's presentation will be uploaded to AHSC YouTube channel. Today's presentation will be done by Dr. Natasha Edwin. We are so pleased to have Dr. Edwin. Dr. Edwin is a hematologist and medical oncologist who specialized in the treatment of patients with blood cancer and blood disorders. Born in India, raised in Sultanate of Oman, she completed medical training at India's top institution, the Christian Medical College, Vellore. Dr. Edwin worked in acute medical care for 2 years before moving to the Cleveland Clinic for her residency in internal medicine, followed by a fellowship in hematology and medical oncology at the Washington University School of Medicine in St. Louis, Missouri. Dr. Edwin is passionate and jealous about putting her patient at ease by personalizing treatment, aligning them with their own values, and empowering them with the knowledge they need to make informed decisions about their cares. She is a member of the American Society of Clinical Oncology and the American Society of Hematology. Dr. Edwin is a strong proponent of participation in clinical trials. She has served on the Leukemia Committee of the Eastern Cooperative Oncology Group and on the board of the directors for the Alliance for Clinical Trials in Oncology. In her free time, Dr. Edwin enjoys hiking, practicing yoga, and playing the piano. Please welcome Dr. Edwin.
Hello, thanks for inviting me to speak to you about a topic that is very close to my heart and a cancer that, a group of cancers that I spend a lot of time working with. So we'll be talking about the basics and beyond of lymphoma. Next slide, please. And in today's talk, we will cover what is lymphoma, what are the various types of lymphoma. We'll talk a little bit about how common it really is, what the causes of lymphoma are, a little bit about risk factors for lymphoma. We'll be covering symptoms, and I'll be spending a lot of time on how we diagnose the disease, how we stage this cancer, and the various treatments for lymphoma. I will also be talking about survivorship and living life after a diagnosis of lymphoma. And we have plenty of time for questions and answers. Each patient is unique, and as much as I would love to be able to help and answer questions, if these are really specific and relate to your own cancer, they're best asked to your medical team. So let's get started. Next, please. What exactly is lymphoma? Lymphoma is a cancer of lymphocytes, which are basically a type of white blood cell. So within the substance of all of our bones exists bone marrow, and bone marrow is basically what you find within the spongy bone, and all of the blood cells are produced within this bone marrow. Blood cells include red cells, white blood cells, and platelets, and they're all produced from blood stem cells. And lymphocytes are nothing but a type of white blood cell. So a lymphoma is a cancer of lymphocytes, which are a type of white blood cell, which are produced within the bone marrow. Next, please. What do lymphocytes do? So also within the body is a system known as the lymphatic system, which is a series of vessels that run through the body that carry immune molecules like immunoglobulins and cells. These lymphocytes flow through the lymphatic channels all through the body, and they come to rest or collect within lymph nodes. There are a total of about 900 lymph nodes spread all over the body, and you can see in this picture representative areas of where lymph nodes are. There are a lot of lymph nodes in the head and neck area. About 300 of the 900 lymph nodes are actually located in the head and neck area. And this is the reason why when you have lymphoma, you have enlargement of these lymph nodes, because they're full of these cancerous lymphocytes. Next, please. What exactly is a cancer? Now, when cells normally divide within the human body, they normally grow and divide and carry out their cell functions. And as they age, they have cells suicide and cells turn themselves off and die. When cancer happens, these cells that are aging and have accumulated genetic changes do not die, but continue to divide and continue to spread and continue to invade other organs. And that's essentially how cancer develops in general. And this is the process in which not just lymphoma, but most other solid cancers develop. Next, please. Lymphoma is, broadly speaking, of two types: Hodgkin's lymphoma and non-Hodgkin's lymphoma. But really, non-Hodgkin's lymphoma is a huge group of diseases. It actually comprises 60 other different lymphomas, and these can be further subclassified based on how they behave into either high-grade or aggressive non-Hodgkin's lymphoma, or indolent or slow-growing or low-grade non-Hodgkin's lymphoma. Another way to classify non-Hodgkin's lymphoma is B-cell non-Hodgkin's lymphoma, or T-cell or NK cell non-Hodgkin's lymphoma. Next, please. In terms of incidence and mortality, Hodgkin's lymphoma is far less common than non-Hodgkin's. In the year 2022, we are projecting that 8,500 new cases will be diagnosed within the US, and Hodgkin's lymphoma comprises 0.4% of all cancer cases and 0.2% of all cancer deaths. Contrast that with non-Hodgkin's lymphoma. There are going to be about 80,000 new cases diagnosed throughout the United States this year. It'll be about 4.2% of all cancer cases and 3.3% of all cancer deaths. Next, please. When we are talking about causes of cancer or causes of lymphoma, we have to distinguish causes from risk factors. A risk factor is something that increases your chances of getting lymphoma, but doesn't mean you'll get it. It's a risk factor is a bit like buying is a bit like a lottery. If you buy more tickets than someone else, you have more chances of winning, but there's no guarantee that you'll win. And the person with less tickets is less likely, but can still win. So a risk factor, having a risk factor for lymphoma is like a game of chance. If something, on the other hand, causes a disease, we know that if this thing happens, the disease will follow. And if that thing doesn't happen, there will be no disease. You can think about a cause like cooking an egg. You know that if you break the egg open and turn up the heat, it will cook. But if you break it open and put it in the pan, but don't turn on the heat, the egg will not cook. So that's how cause is different from a risk factor. So when we talk about causes of lymphoma, we know that lymphoma is caused at a cellular level, at the level of the gene. So just to remind you, cells have genetic material or DNA that is aggregated within the nucleus. DNA is arranged into different genes, and changes or alterations in these genes that make cells divide and grow, or changes in the genes that make cells die when they grow old, essentially cause lymphoma. Next, please. So that's very biology based and very theoretical, but what are the real risk factors for lymphoma? So like I said before, these are just things that predispose individuals to lymphoma. It doesn't mean that you've got several of these that you will necessarily develop it. We do know that older individuals are more likely to get lymphoma. We know that lymphoma is slightly more common in men than in women. Several lymphomas cluster in families. We know that if you've got a first-degree relative, which means a brother, a sister, or a parent with lymphoma, you're at higher risk of getting it. We have identified that exposure to certain herbicides and exposure to benzene is a risk factor for lymphoma, and also radiation is known to be to predispose people to lymphoma. Next, please. Some other things that are risk factors are weakened immunity. So typically people who've had organ transplants, people living with HIV or AIDS, people with inherited immune deficiencies also have poor immunity and can get lymphoma. People with autoimmune diseases like lupus or Sjogren's syndrome. And then there are certain infections which in and of themselves can predispose to lymphoma. H. pylori is a type of bacteria that causes stomach ulcers and has been known to cause stomach lymphoma. Chlamydia psittaci causes lung infection, and that can cause lung lymphoma. Campylobacter causes small intestinal disease and small intestinal lymphoma. And hepatitis C is a risk factor for lymphoma that involves the spleen. Next, please. A common question we get asked is, does using Roundup cause cancer? What we know is that Roundup is basically it's arguably the most widely used herbicide in the world, and it contains an ingredient called glyphosate. When glyphosate is applied to plant leaves, it inhibits certain plant growth enzymes, eventually killing the plant. But because glyphosate is used so often, it's not only found on plants, but it's found in water, soil, food, and also found in small quantities in the human body. When researchers tested urine samples from a small group of people living in different locations in the US, they found that 93% of the samples contained some amount of glyphosate. So all of us essentially have been exposed to this agent. When it comes to the question, does it cause cancer? There is some controversy. The WHO's International Agency for Research on Cancer called glyphosate a probable human carcinogen, which basically means that they have looked at the evidence from exposure in humans and experimental animal studies and found that there is a link between glyphosate exposure and developing non-Hodgkin's lymphoma. And recently, some researchers from Seattle found that high exposure to herbicides containing glyphosates is associated with a 41% increased risk of developing non-Hodgkin's lymphoma. And their definition of high exposure was 2 or more days worth of exposure to Roundup per year. And but the Environmental Protection Agency disagreed with the findings from the WHO, and they've recently been asked to revise or reassess their assessment based on all of the data that we're seeing. Next, please. So in summary, what we've discussed so far, we know that lymphoma develops when mutations happen in the genes or changes happen in the genes affecting the way your lymphocytes grow and work. There are currently no concrete causes for what triggers these changes. Risk factors can increase your chances of getting lymphoma, but having a risk factor doesn't mean you'll get it. Not having a risk factor doesn't mean you won't get it. And it is not a lifestyle cancer. It's not really caused by lifestyle choices like a lot of other cancers. And we really don't have a screening test for lymphoma. Next, please. With all of that said, when people ask what can I do to prevent lymphoma or prevent cancer, we do recommend a few small, simple pointers. This is general advice to avoid cancer in general, and we recommend not starting to smoke, and if you do smoke, getting help to quit, avoiding injectable drug use, avoiding sharing needles, drinking less alcohol, drinking fewer than 2 standard alcoholic drinks a day if you're a man, and less than 1 drink a day if you're a woman, taking minimum 30 minutes moderate intensity physical exercise daily. Moderate intensity means enough for you to get breathless or have difficulty carrying out a conversation, and eating a healthy diet that is balanced in proteins, carbohydrates, vitamins, and minerals. Next, please. People ask about the signs and symptoms of lymphoma. So what are the symptoms of lymphoma? As we discussed earlier, one common symptom when you're having growth of lymphocytes is that you're going to have swollen lymph nodes. The lymph nodes are most readily visible and evident when they're swollen in the neck, under the collarbone or around the collarbone, in the groin, and in the armpit. And this is really the most frequent sign of lymphoma. You can get, when you have lymphoma in the spleen or in the abdominal nodes, you can see a visible swelling, or you can have symptoms of a swollen stomach. That is basically you can feel full easily and have poor appetite. Lymphoma is also known to cause drenching night sweats. Now, a lot of people say that they get night sweats or they feel hot at night. Patients with lymphoma have night sweats that they can actually wring out the sheets. They need to change the pillow covers and change the sheets because they are really drenching night sweats. And we're not really entirely sure why that happens. Some people say it's related to fever. Others don't have clearer explanations than that. Patients with lymphoma frequently feel fatigued. They feel tired despite taking rest, tired despite sleeping well, and that is a common complaint. Weight loss can be related to swelling in the abdomen, but it can also be just by itself. And this is typically unexplained and effortless weight loss. And finally, patients with lymphoma can also get an itchy skin or skin rash. And that is also, even in the absence of any rash, generalized itching may be seen in patients with lymphoma. Next, please. The signs of lymphoma also are determined by where the lymphoma is located. If you've got lymphoma in the stomach, you could get anemia because your stomach is not absorbing nutrients well enough. You can have constipation, diarrhea, or stomach pain. You can feel full after eating very little, and you can feel really tired for no clear reason. Next, please. When lymphoma involves the skin, it typically is seen as patches. You can see in panel A, this is just patchy skin, or plaques where these patches combine together and become raised. And those plaque-like lesions are commonly seen in skin lymphoma. When these plaques grow and are raised above the surface of the skin, like you're seeing in panel C, you can see actual tumors, and that's another symptom of skin lymphoma. And Sézary syndrome is a particular type of skin lymphoma where the skin is just diffusely involved, diffusely and generalizedly red, and frequently sloughs off, comes off because the skin is so dry and red and scaly. Next, please. Lymphoma in the eye is uncommon, but patients that do have it experience blurred vision, small spots that float across the visual field known as floaters, and redness or swelling of the eye and increased sensitivity. Central nervous system, which is the brain and spinal cord lymphoma, is again uncommon, but is associated usually with headaches, nausea, vomiting, seizures, balance issues, and sometimes personality changes. Next, please. Lymphoma within the chest can cause cough, difficulty breathing, hoarseness of voice, chest pain, or pressure. Next, please. A dictum here in lymphoma is that once you suspect lymphoma, you always need a biopsy to diagnose lymphoma. Next, please. Most of the time, a lymphoma can't be diagnosed by a blood test. Blood tests are helpful. They help us find out how lymphoma and its treatment are affecting our body, and they can be used to find out more about your general health. But a blood test doesn't really replace a biopsy. Next, please. There are different types of biopsies that can be taken. The first and the type of biopsy that is the best is an excisional biopsy. And an excisional biopsy is usually done with a minor surgery. It's the most effective way of diagnosing lymphoma in the lymph node. And what it is it's a minor surgical procedure. The entire lymph node is taken out and sent to the pathologist to look at the slides under the microscope. An incisional biopsy is similar to an excisional biopsy, but instead of removing the entire node, only a part of the node is removed. And this is also a pretty good test to diagnose lymphoma. A core needle biopsy is much less invasive than the first two, but it results in a smaller specimen and may not be diagnostic. And frequently, we can't make a diagnosis of lymphoma based on just one core, and we need multiple cores, which are hard to get and hard for the patient also. And finally, a fine needle biopsy is not generally helpful in making a diagnosis of lymphoma. It is more helpful when we want to exclude other cancers. So if there's 2 or 3 types of cancer that are likely, a fine needle biopsy will tell us that it is not, say, kidney cancer or breast cancer, but it will be not helpful in telling us exactly which of the 60 different types of non-Hodgkin's lymphoma it is. Next, please. Another common site of biopsy is the bone marrow. And like I said before, lymphoma usually arises within the bone marrow. So the bone marrow biopsy will help tell us if there is any involvement with lymphoma cells. As I said before, it's found within the substance and center of all the bones. It's a spongy red and yellow looking area that you're seeing there. And we usually take it from the hip bone. Next, please. The way in which we do a bone marrow biopsy is we take 2 main samples, a bone marrow aspirate. We enter the bone marrow space with a bone marrow needle and suction out a small amount of aspirate, maybe 5 to 10 cc's. And then we take a trephine or a core. So we take a small solid sample of the bone marrow tissue, and that is usually no bigger than a centimeter or half an inch in size. Next, please. Preparing for a bone marrow biopsy, we always use local anesthesia, but we don't always use sedation. And we usually say that if you've got anxiety or feel pain easily, talk to your doctor or nurse, and we can offer you sedation before your procedure. It makes you sleepy and you won't be able to drive or operate machinery right after. But we always use local anesthesia for this process. Next, please. And after a bone marrow biopsy, it can be done within the doctor's office. We recommend lying down for 15 minutes afterwards. There should be minimal post-procedure pain. And we tell patients not to get the area wet, the site where we have done the bone marrow biopsy, the hip bone, on the day of the procedure, but you can shower and get it wet the next day. Next, please. Another common test that we use for lymphoma is lumbar puncture. Now, this is a way in which we assess the presence of lymphoma cells within the fluid that bathes the spine and the brain. So the brain and the spinal cord are continuous with one another, and they are surrounded by this fluid known as cerebrospinal fluid. And a lumbar puncture is just a way to get some of that cerebrospinal fluid, or CSF, to look at under the microscope and tell if there is lymphoma or not. And so we do this to tell if there's any lymphoma that is in the central nervous system that is involving the brain, spinal cord, or the area behind the eyes. Next, please. So this is also done under local anesthesia. The doctor will put a needle into the back, and then the cerebrospinal fluid starts to flow on its own. Sometimes the doctor may deliver a small amount of chemotherapy so that the chemotherapy can flow within the spinal cord or within that fluid. Next, please. Now, what we do with all of these tests, what do we do once we get biopsy cores and bone marrows and cerebrospinal fluid? So we do a test known as Immuno Phenotyping. Now, Immuno Phenotyping is a way in which we distinguish between different types of cells. It tells us what are the various markers or proteins found on white blood cells. And this can be done through either immunohistochemistry or flow cytometry. So these are words that your doctor will throw at you. These are words that can be used interchangeably, and these are just literally tests that we're running in the lab to help tell us what exactly is the specific subtype of lymphoma that you have. Next, please. Another group of terms that we use are cytogenetics, FISH, and PCR. And these are tests, additional genetic tests. Now, to simplify it, we know that normal human cells have genetic material arranged within chromosomes. We normally have 23 pairs of chromosomes, each of which is a certain size and looks a certain way. In some types of lymphoma, cells have changes in their chromosomes. You can have too many chromosomes, too few chromosomes, abnormal sizes and shapes of chromosomes. And so cytogenetics is the process of looking at the chromosome and seeing whether there's any structural change. Fluorescence in situ hybridization, or FISH for short, can help us to find most chromosome tests that can be seen in cytogenetics, but also some really minute changes that are not evident on cytogenetics. And it is a very accurate test and can provide results within a couple days. Polymerase chain reaction, or PCR, is even more sensitive than a FISH test, and this can find gene changes that are too small to be seen with a microscope, even if very few lymphoma cells are present. And so doctors will use a combination of all of the above to help make a diagnosis of lymphoma and help tell you exactly which subtype of lymphoma you have. Next, please. We do blood tests in lymphoma, and that helps in telling us the exact type of lymphoma you have, how it's affecting your body. It's useful in checking out your general health. It's useful to see how your treatment is affecting you. It is useful to check to see if you've recovered from one round of treatment before starting the next. It's useful to monitor recovery, check for late effects, and also to pick up any early signs of relapse. Next, please. So the typical types of blood tests that you may have are tests to monitor and diagnose the lymphoma. So blood counts, a peripheral blood smear to see what the blood looks like under the microscope. We sometimes do serum immunoglobulin tests to measure antibody levels. We send liver function tests. We look at kidney function and how it's excreting waste. We look to see if there's any markers of inflammation. We look for viral infections. We look at thyroid function, because sometimes chemotherapy can affect thyroid function. Radiation can affect thyroid function. And we do a blood group and cross match so that we have blood, or we can get blood to transfuse if we need it. Next, please. So a lot of patients come and say that they're afraid of blood tests. And if you're worried about blood tests, always talk to your doctor about it. And there are different reasons why people are afraid. If you feel faint or dizzy when you have a blood test, you can ask if you can lie down when you have blood taken. If you're worried about pain, you can get some numbing cream to numb the skin first. We usually have to, you should usually put it in about 30 minutes before they're poking you, so that it has enough chance to act. But certainly you could use numbing cream if you're worried about the pain. If you're afraid of the sight of blood, look away. And if you feel anxious during the test, you can try some relaxation techniques like breathing methods, or take someone with you to chat to help take your mind off the blood test. Next, please. What do my blood tests mean? So now a lot of times you get blood test reports released to you on your over the computer, and that's released way before you have time to talk to your doctor about it. The blood test will usually list your own result along with a reference range or a normal range. This is the range of values that are seen in most healthy people, and but you have to remember that approximately 1 in 20 healthy people too may have results outside the reference range. The reference range varies between different labs depending on the way the test is performed and the equipment used. So a certain value which may be normal in one lab may be completely abnormal in a different lab. And so therefore, if you have a blood test that is not within the reference range, it doesn't mean that you necessarily have a health issue or something to be concerned about. Next, please. We use scans and order scans a lot in lymphoma, and the reason we do that is to look for the possible causes of certain symptoms, to help determine the stage or extent of lymphoma, to see if the treatment is working, and to see if the lymphoma is coming back after treatment. Next, please. There are two main types of scans that we use: CT scans and PET scans. Next, please. The first group of pictures I'm showing you are pictures from a CT scan. And you can see on the left-hand side, this is a CT scan of a person with a lot of swollen lymph nodes. Right at the top of the screen, you can see a whole bunch of swollen lymph nodes within both this patient's, the upper part of both this patient's arms. There's a lot of lymph nodes within this person's abdomen. And on the right-hand side, there is good response to treatment. All those nodes have shrunk and disappeared. So the CT scan is usually done with contrast, and they are better than X-rays at taking pictures of internal organs and taking pictures of lymph nodes. Next, please. We frequently use PET scans. What PET scans are they are just fancy CT scans. They use a radioactive form of sugar or a radioactive form of glucose to look to see how active the cells in your body are. Typically, lymphoma cells are very active, so they take up a lot of this sugar, and a special camera recognizes the radioactivity in the cells, and these show up as black spots on the scan. So you can see on the left-hand side, these are pictures of black or very active lymphoma within the chest and within the abdomen of this patient, and then following treatment, those previously black areas have completely resolved and you can't see them anymore, which shows that this person has had a complete response to treatment. All the areas that are remaining black are healthy. Those are essentially areas with the kidney and the ureters, which show as black anyways. The PET scan is usually done before treatment to help tell which sites of the body are involved by lymphoma, usually after a few cycles of treatment to help plan the next part of treatment, and finally at the end of treatment to see if the lymphoma has responded or not. Next, please. So we now come to staging. Staging is the process of working out which parts of your body are affected by lymphoma. That is how advanced your lymphoma is. The nice thing is, even though lymphoma has over 60 different types of cancer, the staging system is the same. For Hodgkin and non-Hodgkin lymphoma, there are only a couple lymphomas that are staged differently: chronic lymphocytic lymphoma or chronic lymphocytic leukemia, and skin lymphomas are staged differently. There are 4 stages designated by the Roman numerals 1, 2, 3, and 4. Next, please. And you can see here, starting on the top left is stage 1, on the top right is stage 2, the bottom left is stage 3, and the bottom right is stage 4. So stage 1 lymphoma means there's lymphoma in only one group of lymph nodes or glands. And the diagram shows these in the neck, but they can actually be anywhere in the body. If you look at stage 2, immediately to the right, you see lymphoma that is involving 2 or more groups of lymph nodes, all on the same side of the diaphragm, that is either above the diaphragm or below the diaphragm. Next, please. I'm sorry, previous slide. Stage 3 lymphoma means that there's lymph nodes that contain lymphoma on both sides of the diaphragm. So you see on that just below the stage 1 picture, there's a person with lymphoma that's highlighted in the neck, in the axilla or the armpit, and in the groin. So this is a stage 3 lymphoma because it's on both sides of the diaphragm. Stage 4 is the most advanced stage of lymphoma, and lymphoma that has started in the lymph nodes and spread to organs. You can see here they're highlighting the liver, the spleen, the lungs. That would be stage 4 lymphoma. Lymphoma involving the bone marrow is usually stage 4. Lymphoma involving the spleen alone is not usually stage 4 because lymphocytes can be seen there in general. But usually lymphoma that's involving the lungs or the liver is stage 4. Next, please. So in summary, the signs and symptoms of lymphoma depend on the organ involved, but they usually involve fatigue, night sweats, fever, and node swellings. We always need a biopsy to make a diagnosis, and the more tissue, the better. So that's where excision is better than core is better than fine needle. We sometimes do specialized testing using the cerebrospinal fluid and bone marrow. Genetic testing plays an important role in telling us about the biology of lymphoma and what the prognosis is. And we stage lymphoma using CT scans or PET scans. Next, please. Now we come to treatment of lymphoma. And the first thing to remember is that the goals of treating lymphoma differ. They differ based on the subtype of lymphoma. They differ based on whether the lymphoma is slow growing or fast growing. They differ based on the stage or the grade of your lymphoma. And finally, the goals of treatment differ based on your overall health and ability to tolerate treatments. When we treat lymphoma, we're looking at 3 possible outcomes, or 3 possible positive outcomes. Obviously, we would love to have our patients cured, and we can achieve cure in a lot of patients with lymphoma. If we can't get a cure, we would like to get a complete remission, which means that the lymphoma is completely gone from the scans and patients do not have symptoms anymore, but there is a possibility that the lymphoma could come back. And partial remissions where we do see some lymphoma in the scans or the patient does feel some lymphoma but does not have any noticeable symptoms or any adverse effects from the lymphoma. Next, please. What do you need to do before you embark on this journey of treatment for lymphoma? The first thing is to assemble your team. And treatments for lymphoma are very difficult. It's getting treatment for any cancer is a very, very difficult journey. And so we encourage all of our patients to take all the help that they can. You may need emotional or psychological support. You may need help with more material things like preparing meals or with housework. You may need help with shopping. You may need lifts to appointments. You may need help with childcare. You may need financial assistance. And at the end of the day, maybe all you need is just someone who can listen to you. And a lot of these things are resources for all of these are readily available. Our social workers are very well equipped in helping patients connect with services for meals. There are services for people to get help with housework for free. There are services in which the American Cancer Society used to run a service where they, pre-COVID, where they used to have patients get lifts to appointment. People used to volunteer to drive patients to their chemo appointments. And there are excellent resources to help children come to terms with their parents' diagnosis of cancer. Financial advocates are usually embedded within the cancer care team at your doctor's office. Just ask to speak to a financial advocate, and these are people who are really very well versed with dealing with insurance companies and financial coverage and getting you the best coupons and discounts for your treatment. Fertility preservation is very, very important for young people who have cancer, because treatment for lymphoma can reduce your fertility or ability to have children. And this can be because you can have early menopause or decreased sperm count or decreased sperm quality. And so if you have a desire to continue to have children or to have children after your cancer treatment, it is very important to bring that up with your doctor and ask about what impact your treatment may have on fertility, what options are available to help protect it. And this should really happen before you or your family member starts treatment. Next, please. As I discussed before, how your treatment plan is decided is based on your own general health, any previous health conditions unrelated to your lymphoma, the biology, so what subtype of lymphoma, how quickly it's growing, and also it is determined by how significant or severe your symptoms are. And finally, your own personal preferences play a really important role in how we sequence and decide what treatments to use. Next, please. This is a very simple slide that talks about all the various treatment options we have for lymphoma. On one tier of options, we have active surveillance, chemotherapy, radiation therapy, targeted therapies, immunotherapy, stem cell transplant, and CAR T-cell therapy. If you notice, I've not mentioned surgery. And that's because surgery is unlikely to cure lymphoma. Surgery can only very rarely remove all the cancerous cells in lymphoma. Even for lymphomas that appear to be in only one area, surgery usually leaves some cells behind. And so that's why chemotherapy and or radiotherapy are the usual treatments for lymphoma. Next, please. So to start off at the beginning, wait and watch. For a lot of patients, we see them, we diagnose lymphoma, and then we tell them that we're going to wait and watch, because this is usually employed for lymphomas that are not likely to be symptomatic, or for patients who are only minimally symptomatic, for lymphomas that we cannot cure. And because we have realized over time that treating you before the lymphoma is causing these problems does not make you live longer. And treatment is just as effective if you wait to receive it when you absolutely need it. Examples of lymphomas where wait and watch is a very common strategy are on the slide: marginal zone lymphoma, follicular lymphoma, lymphoplasmacytic lymphoma, nodular lymphocyte predominant Hodgkin's lymphoma, chronic lymphocytic lymphoma, and some mantle cell lymphoma can be waited and watched. And the thing to remember is that this does not mean that there is no treatment available. It just means that we are choosing not to give you treatment now. It does not mean that you're too old or sick to be treated. And it doesn't mean that people are trying to save money on your treatment. It just means that we are trying to avoid side effects for treatments. Next, please. And we are trying to avoid these side effects and treatments for as long as we possibly can. And you will only need to keep getting outpatient checkups. And most people enjoy a pretty good quality of life. Next, please. Usually what we do is we do labs, physical exam, and history every few months. And we educate patients about the symptoms and signs of lymphoma. And your doctor will explain to you what these are for you in your individual case. And if you do have any signs or symptoms of lymphoma, your doctor will bring you back and discuss treatment or do staging tests. Next, please. The next type of treatment is chemotherapy, and this is perhaps the most commonly employed treatment for lymphoma. Chemotherapy means treatment with cytotoxic drugs. Cytotoxic means, cyto means cell and toxic means poison. So chemotherapy is basically poisoning the cancerous lymphoma cells. Chemotherapy works in one or more ways. Either it'll stop lymphoma cells from dividing, so they die off, or triggering the lymphoma cells to die. Chemotherapy is either given as a single drug or as a combination or a cocktail of many drugs, and it is given every few days or every few weeks. And a round of treatment or one course of treatment is called a cycle. After each cycle, you get a small period of rest, and then you get the chemotherapy again. Chemotherapy drugs work on cells that are in the active process of dividing. So it doesn't work on cells that are not actively dividing. And for that reason, because not all the cells in the cancer are constantly dividing, it is given in several rounds so that it hits the actively dividing cells over time. Next, please. Chemotherapy can be given either orally, that is by mouth. It can be given intravenously through the veins. It can be given subcutaneously or under the skin as an injection. It can be given intrathecally, as I discussed before, into the space in the cerebrospinal fluid via a lumbar puncture, or it can even be given topically, that is as a cream on the skin. You can get chemotherapy as a cream also. And the route of administration really depends on the drugs that we're using and the type of cancer that we're treating. Some words of caution for oral chemotherapy. It's important that other people don't touch your chemotherapy drugs because they can be sometimes absorbed through the skin. So it's good practice also for you to wash your hands before and after taking oral chemotherapy tablets. Unless you've been told by a member of your medical team, don't crush them or open these tablets or capsules. IV chemotherapy is perhaps way more common than oral chemotherapy, and this is given through an IV line, and we will come to the various types of IV lines on the next slide. It can be given either through as a bolus, which is a push dose of chemotherapy. So the whole chemotherapy is injected through in a short period of time, usually a few minutes, or it's given as an infusion where the chemotherapy is mixed into a bag, a tube runs from the bag into your veins, and it's given over a slow, prolonged period of time, which can be anywhere from 5 minutes to a number of hours, depending on the drug that you have. Next, please. There are different types of IV lines that we use to infuse chemotherapy. The top left-hand portion of the screen has a portacath in it. Now, a portacath is basically a totally implanted line. It is a line that that is placed from connecting a small bulb within your implanted under your skin into the veins around the heart. The advantage of having a portacath is that it can serve as a way to give chemotherapy, give IV fluids, and also to draw blood. So you really don't have to be poked constantly to get blood tests drawn for monitoring purposes. A portacath is implanted, and once it's implanted, it can be in place for years without much extra care or maintenance needed. The only problem with a portacath is that putting it in is a surgical procedure, taking it out is also a surgical procedure, and so it is slightly more complex than the alternative, which is a PICC line. So on the right-hand side of the screen, you see what a PICC line is. A PICC line stands for peripherally inserted central catheter. Again, this is a line that is placed within a small vein. It goes through the venous system into a large vein surrounding the heart. The reason why it's important to give chemotherapy into one of the larger veins is because chemotherapy needs to get into circulation quickly. We don't want it to be localized only to the arm, because if it is only in the arm, it may not go into the circulation as well, and it can cause injury to the veins around into which you inject it. So it's important to have it delivered into a large size blood vessel. A third type of line, that is the line on the bottom left-hand side of the screen, is called a tunnel central line. It's kind of a combination or a hybrid between a portacath and a PICC. You have the portion of the line that is going into the vein. There is a little tunnel under the skin, and there is also an external portion of that line that is hanging out from outside the chest wall. This is This is called by different types of trade names. It's called a Hickman in some places. It's called a Grashong in other places. And this is also a line that we use to deliver chemotherapy. The problem with the Hickman line is that it needs a lot of maintenance and it needs frequent dressing changes. PICC lines too need frequent maintenance. They need frequent dressing changes once a week. They need to be flushed once a week. And so for a lot of reasons, patients prefer to have ports placed. Next, please. Side effects of chemotherapy. The two side effects that I've highlighted, fatigue and loss of appetite and taste, are universal, absolutely universal. Every single patient on chemotherapy has, to some extent or the other, fatigue and loss of appetite and taste. Other side effects that I've mentioned are less frequent, but also common. In general, chemotherapy may cause hair loss, but usually causes hair thinning. There are certain types of chemotherapy that inevitably or invariably cause hair loss. We know that, or at least some centers have the ability to prevent hair loss by using scalp cooling devices. This is something that has come into vogue with breast cancer. A lot of the breast cancer chemotherapies, like lymphoma chemotherapies, result in hair loss. And so there is a way in which you can reduce the hair loss by using a cold cap to the skull. It is not commonly used for patients with lymphoma, but that is something that we do from time to time. Mouth sores are another frequent side effect of chemotherapy. This can be reduced to some extent by using a salt and soda mouth rinse, by avoiding alcohol-containing mouth rinses, which can be very damaging to the mouth, and also by generally maintaining good oral hygiene. You can mitigate some of the loss of appetite and taste by appropriately seasoning your food. We know that sweet is the last taste sensation to go, so we recommend that patients season their food with sweeter sauces or sweeter condiments. Sometimes patients report having a metallic taste to their food, so we say eat your food using plastic utensils rather than metal utensils while you're on chemo. Nausea and vomiting are common chemo side effects, but because we give excellent medications to control it, a lot of patients don't ever experience it. GI side effects like diarrhea or constipation are very common, and there is an increased chance of infection from shortage of white blood cells with chemotherapy. Bleeding or bruising can be seen because of minor cuts or injuries. This is related to a shortage of platelets, and you can get fatigued or short of breath from too few red blood cells. Next, please. In addition to chemo, we give a lot of supportive care medications like steroids. We give anti-nausea medicines. We give anti-diarrhea medicines. We sometimes give anti-constipation medicines. And we use injected agents known as growth factors that can help increase blood cell counts and reduce the risk of infections. Next, please. Other common questions that we get asked about chemo is how long does chemo stay in the body? In most cases, drugs last a few hours to a few days in the body, but sometimes it takes longer to go out of the system. And how long it stays in the body depends on what type of drug you have and how your body processes it and how your organs are working. People ask if they can drink alcohol while on chemo. It should be generally okay to have an occasional drink between chemotherapy cycles when you feel well, but always check with your doctor. Remember, alcohol can interact with some of your medicines and affect how well they work. And remember, you're very likely to lose your taste, so you will probably not be able to taste it as well. And you may feel the effects of alcohol much more quickly now than you did before treatment. Patients ask if it's okay to smoke. Smoking it predisposes you to getting lung infections, and some types of chemotherapy really carry a very high risk of lung scarring that can even be fatal when people smoke. So when patients are on bleomycin, it is absolutely not okay to smoke even a little bit. A lot of patients ask if they can or they should exercise. We very, very strongly encourage exercise. Physical activity has a positive impact on physical health, on mental health. It may shorten recovery time. And certain types of exercise are probably best avoided, like avoid contact sports if you have low platelets. Sometimes we recommend against swimming because of increased risk of infection from pools, common public pools. But always consult your doctor when you're referring to specific types of exercise. Can you go to work? We actually encourage you to work as much or as little as you can. I've had several patients work right through their chemotherapy, but I've also had several patients who've not been able to work at all. It is all dependent on you and how fit or how well you feel. Is it safe to to have a massage? Sometimes people with lymphoma worry that having a massage can spread lymphoma. There is no evidence that massages are harmful. Speak to your medical team if you have specific questions, but in general, a massage should be just fine. Could acupuncture help me? There is some evidence that acupuncture helps with nausea and vomiting and pain control. And check with your doctor, because sometimes when you have low platelets on low neutrophils as a side effect of chemo, it can increase your risk of bleeding or infection. So check with your doctor before you do that. Should you follow a certain diet? The general guidance is to eat a healthy, balanced diet, but if you're having a more intensive chemotherapy regimen, your medical team may give you some additional advice on or more specific advice on diet. Can you spend time with family and friends if you're immune compromised? So it's important to spend time with your friends and family. They are useful to help with keeping your emotional well-being. We only caution you that if you have neutropenia, avoid being people who are sick. So I'm sure that you can always restrict your guests and visitors to people who are healthy and well. Avoid exposure to sick people. And can you have a flu vaccination? You certainly can have the flu vaccination. Check with your medical team for the timing of the flu vaccination, because it may not work as well when you are receiving certain types of chemotherapy. Next, please. Sexual intimacy and cancer. So having had lymphoma and its treatments, it can make you feel very tired and lack energy. In some cases, you may not feel like having sex, and that's okay. Wanting to have physical contact without sex is okay. Wanting sex is also okay. If you choose to have sex, it may help to use a lubricant, and consider that there is sometimes a risk of infection. There may be a bleeding risk when your platelets are very low. Use barrier protection such as condoms and spermicides, especially in the first 7 days after chemotherapy, to avoid exposing your partner to the chemotherapy, which can be excreted, or the products of chemotherapy, which can be excreted in your body fluids. Next, please. Radiation therapy is another form of treatment. It is a localized treatment, which means that it affects only the parts of your body being treated. Lymphoma cells are very, very sensitive to radiation therapy. Next, please. We give radiation as either conventional radiation therapy, that is high energy X-rays or photons. There are specific types of radiation known as electron beam radiation therapy, which does not travel very far. So it's very helpful in treating skin lymphoma. So it just travels superficially under the skin and does not affect the deeper tissues. Proton beam radiation is especially used in children because this is a type of radiation that does not travel very widely, and so it's very helpful in children. Radiation is either given as a single dose or single fraction to control pain, or in multiple fractions to cure the cancer. And when we are doing transplants, which I will come to later, we do total body radiation to help to basically eradicate the bone marrow. Next, please. Most radiation therapy is planned using a CT simulator scan. You may hear this called a CT planning scan. The images from this scan are transferred to the radiation therapy system to plan your treatment. Unless you're having radiation to the head and neck, you may have some permanent dot-like marks made in your skin. Usually these 2 or 3 tiny dots are lined up with the X-ray beams on the radiation therapy machine to make sure the radiation goes to exactly the right place. And if you are having radiation to your head, neck, or chest, you may have a plastic mask or a shell made. This helps keeps you in the same position for the treatment, so the treatment goes to exactly the right place. And sometimes if you're having radiation to the chest, you will be asked to take a deep breath during the planning sessions to reduce the impact of movement on the area being treated. The CT simulator is like a detailed 3D map that shows exactly where the lymphoma is. And and then following simulation, patients are just taken into the room. They receive treatment. Treatment usually lasts a few minutes. And so a treatment session usually lasts 10 to 20 minutes. Next, please. Side effects of radiation, they're usually early side effects like fatigue, sore mouth, sore skin, hair loss, nausea, but there can also be delayed side effects depending on where the radiation is given. So head and neck radiation is associated with dental problems. Later in life, you can get dry eye, cataract, dry mouth. Neck radiation very, very frequently causes low thyroid function. And radiation to the lung and chest can result in lung problems, lung fibrosis, heart failure later in life. There's a very small risk of developing cancer many years later. And generally speaking, radiation results in increased risk of cardiovascular disease. It increases the risk of cardiac, of atherosclerosis. Patients frequently ask if radiation makes them radioactive per se. Radiotherapy will not make you radioactive. So people around you, including children, are not at any risk from being near to you after you've had treatment. It's usually safe to have radiation even if you have a pacemaker or an ICD in place. And the only times it's not safe to get radiation is if you're pregnant or planning to breastfeed. Next, please. Targeted therapies are treatments or medicines that are specifically designed to attack particular proteins on lymphoma cells or particular proteins that are more common on lymphoma cells. Next, please. The next slide gives a long list of various targeted therapies, the various types of lymphoma that they're used to treat, and their various side effects. The thing to remember from targeted therapies is that they usually don't have the chemotherapy side effects of loss of taste, but they usually do cause fatigue almost universally, and they usually cause low blood counts and risk of infections. Next, please. A very exciting area in lymphoma is immunotherapy. And immunotherapy is it has really changed the field of how we treat patients with lymphoma. Immunotherapy can either be antibody-based or immune checkpoint-based. Next, please. Antibody treatment is a type of targeted treatment. Antibodies are specialized proteins made by the white blood cell. You can see in the picture, this is a cell with multiple proteins on its surface, and these antibodies are these upside down Y-shaped molecules. They help fight infections, or antibodies help fight cancer by sticking to proteins on the surface of the cancer cell, and by sticking to these to the surface, they can either kill the cell directly or help the immune cell find and kill the cancer cell. Next, please. This is a really detailed picture, but if you look very carefully, you can see this is a cancer cell, or a proposed cancer cell in pink. And there are antibodies bound to different molecules on the cancer cell. So starting from the top right hand, you can see that there are antibodies that are bound directly to proteins on the cell surface. And that's one mechanism by which they stick to one protein and they activate the immune system to destroy the cancer. Another way in which antibodies can cause cell destruction is by antibody drug conjugates. So the top left corner of that picture shows you various antibodies targeted that are targeted against cell or cancer cell proteins bound to chemotherapy. So what these do is these antibodies stick to the cell or the proteins on the cell and then deliver the chemotherapy directly to the cancer cell, and thus limit the damage to non-cancer cells. In a similar way, you can have antibodies bound to radioactive drugs. So there are radioactive particles bound to antibodies. The antibody sticks to the cell, and the radioactive protein is delivered into the cell directly to the lymphoma cell and kills the lymphoma cell in a targeted way. the bottom right-hand corner is using a type of antibody known as a bispecific antibody. What that is this is an antibody that has an end that attaches to the cancer cell and an end that attaches to the normal lymphocyte. And this brings the cancer cell to the lymphocyte and destroys the cancer cell. This basically helps the T cells find and destroy the lymphoma cell. Next, please. Another very revolutionary group of immune therapy is specifically known as checkpoint inhibitors. This was the first group of therapy that was approved by the FDA for any cell type that expresses PD-1. So this is the first time they approved a particular immunotherapy drug for any type of cancer, lymphoma, non-lymphoma, just based on the presence of a marker. So what this is that an important part of the immune system is its ability to tell between normal and abnormal cells in the body. And the immune system can distinguish between normal and abnormal cells by using checkpoints on the immune cells. These checkpoints act like switches that are turned on and off. Immune checkpoint inhibitors block the checkpoint system, and so this activates the immune system and results in the immune system getting activated specifically against cancer cells. Next, please. Another type of immune therapy is CAR T cell therapy, which uses patients' own T cells to fight cancer. Next, please. So what this is that T cells are collected from the individual patient. These T cells are sent off to a lab. In the lab, they are genetically engineered or modified to recognize specific proteins on the cancer cells. These re-engineered cells are multiplied in the lab till there are millions of these attacker cells and then shipped back to us, and we infuse these CAR T cells into the patient. These attacker cells recognize and kill cancerous cells, and it's given pretty much like a blood transfusion. And this cancer cell activation this T cell activation kills the cancer cells. Next, please. So you can see here, these are the steps of CAR T cell therapy. The first step is collecting the T cells. It's done through a process known as apheresis. This next step is making CAR T cells. The T cells are sent to the lab where they are connected with another molecule that specifically recognizes a protein on the lymphoma cells, and then these cells are grown. Next, please. Once your CAR T cells are ready, the lab sends them back to the hospital where you're treated. These cells are sent back in a frozen form so they can be stored. You then get lymphodepleting chemotherapy, which reduces the total number of white blood cells in your body. And this prepares your body for the T cells so that they can multiply more efficiently. And then finally, you actually receive the CAR T cells. Next, please. CAR T cells are associated with some specific toxicities or side effects. There's a side effect known as cytokine release, where there's release of chemicals, which causes a violent immune response. You can get fevers and chills and low blood pressure and headache. And almost everyone gets some level of CRS. Most of them have mild CRS or cytokine release, but severe cytokine release will need care in the intensive care unit. There is also sometimes neurotoxicity or central nervous system damage with CAR T cells. This is very uncommon, seen only in 20% of patients, and it usually manifests as confusion, difficulty writing, speech problems. In extreme cases, it can result in seizures, and it usually develops within the first month of CAR T cell therapy. There is a risk of low blood counts and risk of infection, as with all types of treatment. Next, please. Stem cell transplant is a procedure that replaces damaged or destroyed stem cells with healthy stem cells. As we discussed earlier, all cells in the blood, white cells, red cells, platelets, lymphocytes, come from stem cells. And you can use either stem cells collected from the blood, or you can use stem cells collected from the bone marrow. So that's why it's interchangeably called stem cell transplants or bone marrow transplants. Next, please. There are different types of stem cell transplants. There are autologous or self stem cell transplants, or allergenic or donor stem cell transplants. In autologous stem cell transplants, your own stem cells are collected and frozen. You have high-dose chemotherapy to kill the lymphoma and kill all the other stem cells in your bone marrow. And then we reinfuse your own collected stem cells. They are thawed and given back to you, and these then grow with and repopulate your marrow with new healthy cells. Allogenic transplants are when you have a donor. So stem cells are collected from a donor, and you then get high-dose chemotherapy. You're then given the donor stem cells to repopulate your bone marrow and build a new immune system to recognize and fight the lymphoma. Next, please. Life after lymphoma. So how you recover from all of the various treatments is very individual dependent and depends on the treatment you had, the side effects you experienced, your age, your general fitness, other medical conditions. And the time you take to feel better really varies depending on what type of treatment you had. And for a lot of patients, while finishing the treatment can be a relief, a lot of patients have continued challenges in the weeks, months, and even years after the treatment is finished. After months of hospital appointments and frequent contacts with the medical team, for a lot of patients, just being done with treatment makes them feel anxious or isolated, and they feel that they don't really have good support. Next, please. Timelines for recovery, we usually see mouth sores or mucositis come back within 2 to 3 weeks following chemo, a little later than that following radiation. Hair grows back within 3 to 6 months following chemo, within 6 to 12 months following radiation. The rest of the side effects, like chemo brain, which is basically changes in memory, thinking process, and concentration, can take weeks to months to get better. Fatigue can take many months to get better. And neuropathy or nerve damage really can improve 6 months or so later. Immunity too takes up 6 weeks up to 6 months sometimes to completely improve. Next, please. Things to watch out for after completing treatment are signs and symptoms of relapse. These usually include enlarged lymph nodes, a lot of the symptoms that brought you into the hospital the first time around: drenching night sweats, unexpected weight loss, worsening fatigue, diarrhea, rashes. And patients with lymphoma are at risk for cardiovascular disease and other bone marrow disorders. Next, please. Finally, as we come to the end of today's talk, the take-home points are that lymphoma is a heterogeneous group of over 60 different types of cancer. We always need a biopsy to diagnose it. We don't completely understand the cause of it, and we don't have screening tests for it. Treatments have to be individualized. It usually comprises chemo with or without immunotherapy and radiation for early stage cancers. For relapse cancer, we use targeted therapies, CAR T cells, and transplant. And life does not completely return to normal after a cancer diagnosis, but there are ways in which to cope. Thank you for your time. Thank you for your patience.